good evening to everyone, to this nice audience that joined this webinar of the UEMS section of surgery. I will introduce myself. I am Michelle de Oliveira, HPB surgeon at the University Hospital Zurich. I am the vice chair of the UEMS division of HPB surgery and the chair of the exam board. And it's a really great pleasure to be here and moderate this webinar promoted by the section of surgery. And for that, we will have tonight a very important topic to discuss. It's about evidence-based management of bile duct injury at laparoscopic cholecystectomy. And as an invited speaker, it's my honor and great pleasure to introduce to the audience Professor Ajit Srivardhana. He is our very good friend and enthusiastic about education, training, innovation. And that's how we talk a little bit about his background. He studied medicine at the University of Manchester and then trained in general and hepatobiliary surgery there. Also, he did many fellowships in Edinburgh, Paul Bruce, and he many places in the United States. He moved to his current position as consultant surgeon at the Manchester Royal Infirmary in 1999 and was appointed professor of hepatobiliary surgery at the University of Manchester in 2008. He received many awards and a prestigious silver scalp as the best surgical trainer in UK. He is a very dedicated clinician. He is a very dedicated trainer, and he likes to educate, to innovate. And for that, he has focused on liver and pancreas cancer surgery, and his research interests are pancreatic inflammatory disease and metastatic colorectal cancer. Very recently, he has done a very important study about the guideline how to manage the colorectal liver mets. So I'd like to share with you the presence of tonight, and on behalf of the division of the HPB surgery, I'd like to thank you very much, friend and nice and very supportive for all achievements, Professor Srivardhana Ajit, that's our current president of the European African Hepatopancreatic Biliary Association. Please, Ajit.
Wow. So thank you, Michelle, for that astonishing introduction. Michelle has been a brilliant leader for EHPBA in the UEMS exam. I know how hard she works for that exam to make it fair, to make it a good assessment, and to make it a modern assessment. So when they asked me to give this talk, it was my honor to do this. So I'm very happy to be here today.
I will stop sharing mine, and then perhaps.
Can you see my screen now?
Yes.
Perfect. Okay, so I will carry on from here. So for the audience, even though most of my time nowadays I speak about the management of people with metastatic colon cancer to the liver, in many ways, this is a much more mundane but much more critically important topic, because not only do HPB surgeons do gallbladder surgery, people whose practice is in visceral surgery or general surgery will all meet gallbladder surgery, especially those who are doing emergency surgery. So this talk works in 3 scenarios. I'm going to talk first about how to anticipate the situation where there might be a risk of bile duct injury, so you can anticipate and forewarned, you can be try and reduce the risk of that. Then what to do intraoperatively to reduce the risk of damaging the bile duct. Then what to do if you think that there might be a problem. And lastly, a little bit about categorization and management of bile duct injury, and that is the evidence-based component of this talk. So if we look at this, starting with the keys to avoidance of biliary injury at laparoscopic cholecystectomy, the absolute key and the lesson to take home from this is to anticipate when you might be walking into trouble. This can be a difficult situation if you're an attending. It happens to me not infrequently where one of the trainees has started doing a gallbladder operation, then I get called for help. So if it's my own patient, I try and anticipate the high-risk scenarios. And there are three. First is Tokyo grade 3 acute cholecystitis. So the Tokyo grading of acute cholecystitis has very quickly become established as the standard method for assessing and categorizing acute cholecystitis. Tokyo grade 3 means that it's a nasty inflammation associated with organ dysfunction and systemic illness. So you know this is going to be a difficult operation. And if you feel, okay, difficult operation, patient is very ill, you can always think about a percutaneous cholecystostomy instead of surgery. So that's to try and avoid getting into the scenario before you get into it. The other two situations which are high risk are the patient with chronic cholecystitis, typically the older female patient with a very small shrunken gallbladder. It can be about that kind of size. Difficult to, and the trouble with the gallbladder that size is that by the time you have encircled what you think is a cystic duct, it's actually the common bile duct. So chronic cholecystitis. And third, and this is a problem in the UK, but probably a problem globally, is patients who wait a long time. So if you wait a long time with recurrent inflammation and sepsis, then the callous triangle becomes adherent. As you get more and more inflammation in more and more episodes of inflammation, callous triangle becomes fibrosed and it becomes very hard to get a critical view. So these are the three scenarios which, if you are thinking about doing a cholecystectomy, be careful. So Tokyo grade 3, chronic cholecystitis, patients with a long wait. So that's before surgery. Now let's move to the intraoperative situation. How do we do laparoscopic cholecystectomy safely? And every single step is important. They're not overly complex, but optimal port placement. So how you place your ports makes a difference. I favor the standard 4-port method. You can do it with 3 ports, but I don't think you get sufficient traction on callous triangle. I place the first port at the umbilicus by an open cut down. So I don't put that blind. Open cut down means a small transverse incision just below the umbilicus. We find the umbilical raphe, incise the umbilical raphe, spread it with blunt forceps, and then put a blunt port in there, nothing sharp for that first port. Because if you think about it logically, that first access into the peritoneal cavity is slightly blind. So to reduce the blindness of it, an open cut down makes it safer. Every other port is then placed under direct vision. So the epigastric port, which I put in next, mustn't be too low, and it has to be to the right of the falciform ligament. Otherwise, you're fighting with the falciform all the way through the operation. The gallbladder grasping ports, the 2 5-millimeter ports, have to be placed sufficiently laterally to avoid a clash with the camera and sufficiently proximal to allow gallbladder elevation. So this is a diagram, safe laparoscopic cholecystectomy. So this, because this is a slightly larger person, the umbilical port is actually placed supraumbilically, but normally I'm just below it. And this port is in the epigastrium, slightly to the right of the midline. What we don't want to do is that. So that's too low. And then you're looking at a tunnel when you're dissecting, and that's a high-risk maneuver. So you need to avoid too low. We need to be there, not there. The 2 lateral ports can be here. You can put these a little bit lower, can put them a little bit higher, but they need to be far enough away from here to allow basically what I've shown there is triangulation. So the camera is looking at the gallbladder, the working port is here, the triangulation port there. So this completes a triangle And then this one is just to hold the fundus of the gallbladder. So that's port placement. The next important step is the first thing we do when we grab the gallbladder, the grasp, and that grasp should be high, not too low. This is a diagram from a Stephen Strasberg paper about biliary injury at laparoscopic cholecystectomy. So the first grab is there, and then the second grab is actually still on the gallbladder, not down there, because if you're here, then the dissection very easily risks damaging the bile duct. So the port placement, the grasp is important, not too low, but to be high. Okay, and then the critical view of safety, and this is the Strasberg group and others have really identified this really importantly. So we identify cystic duct, cystic artery, and I know critical view is not important. So critical view means that you can see a common bile duct. Above it, you can see a common hepatic duct going towards the hilus, and from it, there's one structure going to the and a cystic artery coming to it, nothing else. That's easy in a relatively uninflamed gallbladder, but in a difficult inflamed gallbladder, that can be very, very difficult. So the critical view is not always possible. What do we do if it's not feasible? You can consider conversion. And one of the second, as I say here, is that conversion from laparoscopic to open is not a failure. Bile duct injury is a failure. Conversion is never a failure of laparoscopic cholecystectomy. Once you've converted, you can think about an open subtotal cholecystectomy. What's important to do when you've converted to an open procedure is to remove the obstructing stone. Otherwise, the inflammation still stays there. I had a phase of oversewing the cuff of the remnant gallbladder, and I leave a drain. Now, even if you oversew the cuff, once you remove that stone, there's a risk of bile leak. But my thinking is that if you oversew the cuff, you've closed the size of the defect. Alternative, once you've converted, it's always an option to abandon the procedure, and you can, depending on your resources and where you are. We realized that when we did the COVID study, which was 10,000 patients having cholecystectomy during COVID, there are many places where surgeons with very limited experience have to do cholecystectomy because there's nobody else to do it. So in that situation, you can convert and you can actually leave a drain inside the gallbladder, so a surgical cholecystostomy. What about intraoperative cholangiography? So this is a paper from 20 years ago, the David Flume paper, which was published in JAMA. It's the only paper I use for this one. Now, US cohort data tend to have very large numbers of patients. But this, even by those standards, is really quite striking. It's 1.5 million laparoscopic cholecystectomies with 7,911 bile duct injuries. And you can see that the percentage of bile duct injury in patients having intraoperative cholangiogram was 0.39%, 0.58% in those having it without. So first thing you can say from there is having an intraoperative cholangiogram doesn't absolutely protect against having a bile duct injury. There was a high risk. It's this graph that I quite like. So this is the frequency with which surgeons do intraoperative ultrasound, IOCUs, can be up to 90%. Those surgeons have a rate of bile duct injury, which is about 0.4, which is much less than surgeons who don't use intraoperative cholangiogram. So I think we can't conclude from this that you have to do an intraoperative routinely, but it is a useful technique to be able to know and to do, especially if in your hospital you have the Nathanson forceps, which allow the cholangiogram cannula to come through the hollow of the tube, and then you can grab the cholangiogram cannula when it's in the cystic duct. So let's say the difficult gallbladder discovered intraoperatively. What can we do? Option one is to abandon. So back out, leave a drain. The trouble with that is it doesn't fix anything, and the patient is worse because they've had a general anesthetic and an operation. And it doesn't help with a gangrenous gallbladder. If you have a non-gangrenous gallbladder, this is an option. You leave the situation alone, it'll gradually get better. If inflammation settles, and doesn't happen that you would reattempt the surgery, typically that gets referred to a specialist HPB unit. And I always say, if you have this patient referred, a patient in this scenario with an abandoned cholecystectomy, referred to you to do cholecystectomy, make sure you have a CT scan prior to reoperation, because you don't want to walk into a situation where there's a big abscess. So the second one, first one is to abandon and go home. Not all that helpful. Second is conversion. So I usually say conversion is not a sign of weakness, poor surgical skill, lack of courage, lack of moral fiber, or all of the above. It's just important to think about the patient there and not the surgeon's ego. It can be difficult to take the entire theatre team along with you. So we often find there'll be one of the trainees who will be saying, oh, let's keep going. Let's keep going. Look, there's a plane there. And that's a way to get into trouble. If the operation is not progressing forwards, then you have to reassess. You don't necessarily have to convert. You have to reassess, think about your options. So if we're going to convert, these are the ports for a laparoscopic cholecystectomy. The 2 5s are a little bit too high there. What I usually teach is avoid joining the dots, because if you join the dots, you end up with an incision which is very painful. It's right under the costal margin, and it doesn't necessarily give you good access. So a separate small cocker incision is better. Port sites can be used for a drain. What I often do is start here and then come over a little bit towards that way. You don't need to be a huge incision, a small thing there. There'll always be air. There'll always be blood, sometimes be bile. If you can get one blade of a fixed costal margin retractor in there, it gives you good retraction if that's available. If we're called out to smaller hospitals, often that isn't available. What are the reasons for conversion? So conversion for bleeding. Bleeding can be from 2 broad areas, from callous triangle, which is very dangerous. So bleeding from callous triangle, I met 2 years ago, had to go to another hospital to deal with a patient where the right hepatic artery had been transected during an attempted laparoscopic cholecystectomy. And they said, can you come and reconstruct this? And the answer was no, because the distal end was really not easily recognizable because there's tissue loss. And the proximal end had been damaged quite badly by multiple attempts to grab it. So we did a transfixion suture. I looked after the patient. He's been fine. So typically you won't get an ischemic right liver from ligating the right hepatic artery. What's more dangerous with the callous triangle bleeding is putting blind sutures in, because you can damage the portal vein or more easily the proximal common hepatic duct. So pressure, try and occlude the vessel under direct vision rather than blindly grabbing with forceps. Okay, so that's bleeding point 1. What about from the gallbladder fossa? Well, the middle hepatic vein and its end branches run into the gallbladder fossa. So a big bleed from there is typically due to end branches of the middle hepatic vein. These respond to pressure. I put Surgicel there, or any other surgical hemostat. We use Flow Seal a lot in our hospital. It may require a single suture, but in fact, I was going to change that because I very, very rarely put a suture into the gallbladder fossa, especially towards the top, because it always cuts out. That angle doesn't favor that. It cuts out and then you get a bigger bleed. So it's better to accept that you've got a bit of a bleed, put some pressure. If it's a middle hepatic vein end branch, because it's a venous bleed, it's always high flow, low pressure. It looks bad, but it'll stop with pressure. This is a middle hepatic vein injury at laparoscopic cholecystectomy. I'm not going to show the video because I'm not sure that it'll project, but basically this stopped with pressure, and you can see there's all sorts of attempts here to try and suture it. Okay, so that was conversion for bleeding. What about conversion for uncertain anatomy? So option One is to do a subtotal cholecystectomy, and that is what I tend to teach because that's safest. If you're going to do a subtotal cholecystectomy, so be sure to leave Hartmann's pouch behind, remove the obstructing stone, remove the fundus of the gallbladder, oversew Hartmann's pouch. Leave a drain there because there's a very high risk of postoperative bile leak, which can nearly always be fixed by an ERCP. Okay, so what to do if we suspect a bile duct injury? Suspected bile duct injury can be for several reasons. Bile is noted during the dissection, the anatomy remains unclear, and you see bile coming either from the hilus or the duct. That's a bad scenario. So the key there, intraoperatively, is to try and define the anatomy and call for help. I usually say if you are the surgeon who's got into that situation, it's sensible to get somebody else because they arrive, they're a cool, calm head or a cooler, calmer head. They can look at the situation and assess it. I will try and do, if I'm called into that situation, I will probably try and do an intraoperative cholangiogram. It might help, but it's not mandatory. One of the things that people teach, which I disagree with, is about the use of a hepaticojejunostomy if there is a bile duct injury recognized at operation. So I usually say, don't convert a partial transection into a complete transection. Why? This is the Strasbourg-Helton paper of the blood supply of the common bile duct. So you see the 3 o'clock and the 9 o'clock marginal arteries, but there are so many little branches. If you have a transection like that, a partial transection, there will be blood supply in the posterior aspect of the wall of the bile duct and the medial aspect of the wall of the bile duct. If you repair it primarily, it may stricture, but a primary repair keeps the option for endoscopic access. So, last and worst case scenario, management of bile duct injury recognized at operation. So primary end-to-end repair is feasible. There are a good series of that. I personally avoid a T-tube. I don't think it's logical. If we go to this situation, have a transection here, and we repair that, then we make another hole to put a T-tube. I don't think that makes sense. A T-tube to drain the bile, I favor avoiding a T-tube, primary end-to-end repair, and leaving a surgical drain. If there is a late stricture, which is quite common if the blood supply is compromised, there is endoscopic access. So that's the major advantage. So you can have endoscopic access, you can dilate it endoscopically. And the advantage here is that if you do have to do a hepaticojejunostomy, the problem with this situation is that if the arteries are damaged, the stricture migrates proximally. So if you repair it here, there's a very high incidence of post-repair hepaticojejunostomy stricture. Whereas if you can wait and repair it at 3 months or 6 months, and that hep-cheg can be much higher, or you can take it what's called the hep-quino method into here, there's a much lower chance of stricture. So what about the classification of biliary injury? This is Stephen Strasbourg's classification, which is probably the most widely used. There is the ATOM classification as well, but he calls them A to D are minor, and E is a major bile duct injury. I don't agree with all of this. So the Strasbourg A, biliary injury, the most important thing to say about that is it's not a bile duct injury. It's a cystic duct stump leak. So where's the injury? The treatment for that is an ERCP and an endobiliary stent, and that's that. Strasbourg B, which is when there is a separate right posterior sectoral duct which has been ligated. I think in real life this is very rare and it's often not recognized. You might see a subtle bit of atrophy of the right posterior sector, but actually this very rarely, I would say, never requires any intervention unless there's a bit of sepsis in this obstructed right posterior sector, which again is rare because it normally atrophies. More commonly than B is C, where the right posterior sectoral duct is open. And that can be a little bit of a problem. We have a patient currently in our wards with that after a laparoscopic liver bed resection for gallbladder cancer. So if there's a leak, we typically do ERCP and place a stent. And the interesting thing with that patient, with the ERCPs, you could not see a leak, and you could only see the right anterior sectoral duct. So I said, that must mean that there's a disconnected right posterior sectoral duct, and the leak will continue after ERCP and stent, which of course it did. So if there's a disconnectedness, so then people said, what do we do? So we've got a percutaneous drain into this. It usually dries up by itself. It's just a question of being patient, making sure the patient doesn't have multiple foci of intra-abdominal sepsis, making sure that nutrition is attended to by nasogastric feeding or nasojejunal feeding if possible. Let's see. D is this one. And again, so far I've disagreed with A, B, and C. I disagree with this because I think the problem with this is that this diagram has this injury on the wrong side. I think it's there. So this is very hard to do. It's very hard to damage the left side of the proximal common hepatic duct without damaging the hepatic artery. So this one, if it's here, that's probably not uncommon. And in that situation, I use primary suture. Doesn't need a hep judge because then you're converting a partial transection into a complete transection. And be aware of late stricture. Finally, Strasbourg category E, and E is how much of the common duct is intact. This does need a hepaticojejunostomy. This is a patient that I fixed. So you can see the PTC shows that there is the left ductal system, right anterior, right posterior, and that they're intact, which is different from a perihilar cholangiocarcinoma type. These two are separated. The other interesting thing about this is that you can see there are lots of clips. So a lot of clips indicates that there may have been trouble during the operation. So what do we do in this situation? This is an E3 injury. So taking you through the steps of a hepaticojejunostomy for an E5 stricture. So if we have this, if it's recognized intraoperatively, I would favor primary repair. So we said that if you have at least part of, so if we think of that logically, if at least part of your duct is intact, try and avoid converting a partial to a complete, to a primary repair. If the duct is completely divided at operation, it doesn't work to join it together because there's tissue loss. That is a situation for a primary repair with an immediate hepaticojejunostomy. The debate, early versus late repair, is really all about the proximal migration of the stricture and also about the skill set that's available and also about the time of recognition of the injury. So the worst case scenario is the patient where they have a complete transection and it isn't recognized at the time of operation until the patient is critically ill 2, 3, 4 days later. In that situation, I have done a hepaticojejunostomy, but it's very hard to do that. In that situation, it's almost always safer to establish percutaneous drainage of the peritoneal cavity, deal with nutrition, identify the anatomy, and then fix it later. So if we're going to fix it, I do this with the right subcostal incision. Typically, the duodenum and colon will be tightly adherent to the base of the liver. So you have to be prepared for that. Spend some time separating those two from there. I use the falciform ligament as a landmark. It's a very obvious, it's a very constant human landmark. Once you've got falciform ligament, if you come down to the right of that, you've got the base of segment 4. And remember, there may be no extrahepatic bile duct. The last one of these I fixed, there was a single tubular structure going from the duodenum to the base of the liver, which is the main portal vein. So use the falciform ligament to identify segment 4. In that situation, we had to, I used the Kusa for liver transection. We had to use the Kusa to clear out part of the base, part of the parenchyma in the base of segment 4 to identify bile duct intrahepatically. But normally, there will be a little bit of bile and there'll be a bile duct visible just beside the lower surface of the liver. So trace down to the hilar plate, which is the reflection of peritoneum, onto 4. Take care not to cause damage to the hepatic artery or the portal vein. I think it's quite wise, if possible, to place a Pringle sling so that you can occlude inflow if you need to. If there's a bile duct outside the liver, I always aspirate that so I know where the bile duct starts. Once the duct is identified, I open it transversely. I'm going to have to go back to get to that picture because I removed that slide. So by that, I mean this, that the Hep Quinault method. Claude Quinault was the French anatomist who really described the segmental anatomy of the liver. So open there up to, so this is the falciform will be here. This is segment 2, segment 3, 4B feedback. So you can open quite easily up to just short of there. This is quite a constant artery, this transverse hilar marginal artery. Quite easy to damage that. So it's like doing the Kasai procedure in infants. You really, really don't want to compromise any of the blood supply to the hilar plate area. So the Hep Quinault is open, this one, up to about there, and that's at least 1 centimeter. And that means that the hepatococyginostomy will not stricture the left side. The right side is much harder because the right posterior sectoral duct originates often just there. And there's a very short common hepatic duct. So we open them. So if the left hepatic duct has a long extrahepatic course, you can open it up to just short of the falciform or just short of the 4B branch. And reconstruction is with a roux loop, and that's the Hep Quinault. And that approach does have an incidence of stricture, but the incidence of stricture is less if it's done electively, if there's good blood supply to the remnant liver, and if it's done after sepsis has been drained. Length of the roux loop, it used to be said it had to be 60 centimeters. I don't think that matters particularly. So in summary, before the operation, nobody used the Tokyo classification of acute cholecystitis. 1 and 2 can be managed easily by laparoscopic cholecystectomy. Grade 3 is challenging, and you can think about using a percutaneous cholecystostomy first. When we get to doing laparoscopic cholecystectomy, to do it safely, every step is important. That's the reason why I say that is it's quite tempting to say, I will get the very junior surgical resident to place the ports, start the operation, then I'll go and join. And by that time, the mistakes which summate lead towards a problem have already happened. So it doesn't matter if the junior resident is going to do it. Of course, young surgeons have got to start somewhere, and this is a good place and a good operation for people to start. They just need supervision. So every step is important. Correct port placement, correct grasp, not too low, critical view of safety, if uncertain. So the options include conversion, abandon, and drain. If there's a biliary injury, define the anatomy. Think about doing an intraoperative cholangiogram. Don't convert a partial to a total injury. Repair can be done with a immediate hepatococyginostomy, or if there's a lot of sepsis and bleeding, a late repair. People tend to have debates, early versus late repair. I don't think it's a debate. If you can do it early, do it early. But if you can't do it early, do it late. Thank you for your attention. 35 minutes. Thank you. Oh, you're mute, Michelle.
So thank you very much for this great presentation. And now I would like to talk to the audience, because in the beginning I wait a little bit. As we have now more, we can explain. We go now for a question and answer. So you
Sure.
please use the button for the questions, and you write and we go through it. I think you have one question right now.
I could answer that. So, wow, a lot of questions. So,
thoughts
on robotic cholecystectomy. Shall I speak rather than type the answer? Because then
Yes.
everybody.
Yeah, I think
So,
it's better.
That's two components: robotic cholecystectomy and indocyanine green. We use in Manchester, I don't personally do robotic cholecystectomy. We have the CMR robot. My two colleagues, Saurabh Jamdar and Ali Sheen, do robotic cholecystectomy. I watched Saurabh do a robotic cholecystectomy recently, and it's a very nice technique. It's a very nice technique for an easy cholecystectomy. He is using indocyanine green, and I think ICG given preoperatively to identify the bile duct is a really good development. It helps to show the common bile duct. We use it also in laparoscopic liver surgery. It's very useful. So it's a useful technique. Strongly support that. Melika is asking about how long we should wait for a late injury repair. Thank you for that question, because I don't think I covered that fully in the talk just because of length of time. So traditionally, people talk about immediate or late repair. I think what we tend to do in the UK is that if a surgeon has a bile duct injury, we advise them to, if they recognize it, to call. And what I do in that situation is I go there rather than patient coming to me, because the patient is usually asleep. Well, he's always asleep. So it's a 3 or 4 hour operation. It's been going for a long time. It's a lot easier to go there. I take some fine sutures and stuff like that. So if it can be repaired primarily, it's probably best to repair it primarily. If you can't, in other words, the patient is presented with sepsis and is ill, then the time to wait is, it's really difficult in this situation, because there's a patient who will have come in to have had a gallbladder operation, will have expected to be home in a day or two, and suddenly finds themselves, someone says, okay, you've got to wait 3 months. So I don't think there is evidence to state that you have to arbitrarily wait 2 months, 3 months, 4 months, 6 months. I think the principles of late management are very, very simple. They're the same as managing sepsis or intestinal fistula. So first of all, control the sepsis. 2, identify the extent of the injury by 2 things. We would do an MRCP, and typically also we would do a PTC with an intraoperative, with a percutaneous cholangiogram, because that shows where the injury is. So control the sepsis, define the injury, improve nutrition. So fine-bore nasogastric tube, get the patient better. I wait till the albumin is back into the 20s, and that typically is about 6 to 8 weeks. It's a very, very difficult time to wait. There'll be an unhappy, angry patient, unhappy, angry family, but I think that wait is key, because I usually say, look, I'm really sorry that something bad has happened. We're going to fix it. Just be patient. So that's the answer. There isn't an actual time, but the principles are identification, controlling sepsis, and nutrition. Next question.
Yeah.
Yes, please.
Here another question about if you recommend systematically MRI before a programmed cholecystectomy. Do you?
Wow. No, so in the NHS, we don't, because money is an important thing. But I think if someone has, we don't routinely do an MR before cholecystectomy. I think medical legally, you must do liver function. So you have a couple of things. You need to take it back from the start. You need to think about a clinical history. Are there episodes of jaundice? In that case, there's a history of something has happened to the main bile duct. You might need to think about imaging then. And are there abnormal LFTs? So in a patient with no history of jaundice and normal LFTs, we would not do a routine MR beforehand. Best time to give ICG before the operation? That's a good question, Ayad. It depends on what you want to do. So there's some very sophisticated techniques where people do intraoperative ICG injection to positively visualize the portal pedicle for liver surgery. We're not talking about anything that complex. We're just talking about giving it to show the biliary system. And we give it usually about 12 hours beforehand, that kind of time.
May I go now with the topic about the difficult gallbladder, the conversion to open? I think there is a question from our audience that I also would like. And the question is what about laparoscopic subtotal cholecystectomy instead of
Yeah.
open subtotal cholecystectomy when the
Yes.
difficult
Thank you, Patrick.
gallbladder? And
That's a
I would
yep.
like it to add, because there are exactly what you said, limit experience, and it maybe it's difference in the generation, because the younger generation has very difficulties when they have to convert to make an open cholecystectomy, which they are not used, so they don't feel comfortable with that. And
Yeah.
also we have these two situations. Either you need to convert and the surgeon has not enough experience, or to with laparoscopic also you could access to subtotal cholecystectomy. I would like to hear your opinion about that.
Thank you, Michelle, for highlighting that. I'm happy to answer that. It's a really good observation. So in the UK, the kind of average volume experience of someone looking for an HPB general surgery job in terms of how much laparoscopic cholecystectomies they will have done is between 160 and 200, that kind of volume. Some will have done a lot more. But the average number of open cholecystectomies in the same period is usually less than 10. So exactly as you say, there's a generation that's good that who do elective open cholecystectomy. I only do during a cancer operation for something else, either Whipple or liver resection. It's very, very rare to elective open. So I think laparoscopic subtotal is a very good suggestion, Patrick. I think that's a perfectly safe thing to do. The principles there, we're saying we can't get a critical view of safety. We're going to open the gallbladder well away from the callous triangle. Should you just staple across the gallbladder at that situation? I have done that, but I think that's not a good thing to do, because that leaves the obstructing stone and that leaves a tiny little remnant of gallbladder which is inflamed. So I think it's better to open to show that you've got a little sort of cup of Hartmann's pouch, remove the stone, and then it is a recognized technique to leave it open and put a drain into there.
Next question is, do you need a reoperation for patients with subtotal cholecystectomy?
Yeah, very good question. So the simple answer is no. But if there is a proportion, we don't know what proportion, because obviously a lot of patients have subtotal cholecystectomy and many are never seen again. If you have a subtotal cholecystectomy and you get recurrent cholecystitis in it, because there's an obstructing stone, then yes, it will end up needing surgery for that one. I used to say that meant it was an open operation, but actually that's not necessarily the case. You will invariably find that colon and duodenum are stuck to Hartmann's pouch. But if you can separate those, because we're in an elective situation without that much inflammation, it's quite often possible to do a laparoscopic completion cholecystectomy in somebody who's had a previous lap subtotal.
And have another question for you. That's good. The audience is
Good
very
questions.
active.
I have to say, the participants, I can't see you all, but your questions are very, very good. I'm impressed.
So how would you manage a bile identify post-op, for example, 2 or 3 days after? Specifically, would you do a laparoscopic washout or ultrasound guided drainage? Or the former, would you repair at that time, given the 2 to 3 days post-op?
Yeah, very good question. Thank you, Hamel, for that question. So I guess what we're talking about is the management of a post-laparoscopic cholecystectomy bile leak. And I guess there's a step before that as well, which is the patient who is ill after lap chole. So what we try and teach the residents is that if somebody is needing, there's actually good evidence that if you need more than 2 or 3 doses of opiate after laparoscopic cholecystectomy, your chance of having a problem, not necessarily bile duct injury, but chance of having a bile leak or a bleed or a hematoma, significantly higher. So let's say we have the scenario of the patient who's had a lap chole, typically won't have a drain, but is unwell and has got pain, or has had it done as a day case and has come back to the emergency room. Those are really common scenarios. And our standard protocol in that situation is to do two things: liver function test and ultrasound scan. Let's say the ultrasound scan shows a collection. We would then have a percutaneous drain because we want to know what it is. Actually, let me take a step back from that. Patient comes back. It depends on the abdominal clinical findings. If they are unwell, unwell without generalized peritonitis, they will always be tender. We would do an ultrasound scan, shows a collection, drain. If they're unwell with generalized peritonitis, typically a CRP 300, there are two important possibilities. It might be that there's a problem like a bile leak or a biliary injury, but it's also possible that there's an unexpected or unsuspected visceral injury. So that is a situation where you could think about a laparoscopy. And then typically in that situation, you won't find and it's quite easy to put the ports back. And when I put the ports back there, I'll have a look through the umbilical port at the liver, but also from the epigastric port down towards the umbilical port to be sure that there's no visceral injury down in the small bowel, down in the pelvis. So if you're doing that situation, so we're reoperating for peritonitis, we found a bile leak, I think you do a washout there and put a drain and come out. If you find a cystic duct stump leak, I have done this once or twice. I've been able to either suture or reclip the cystic duct stump. The difficulty is that it's friable tissue because it's been leaking bile for 2 or 3 days. It's probably safer just to leave it drain and come out. So if we go back to the first scenario, bile leak, drain put in, bile is coming, and then we would do an MRCP to identify what's going on, and then probably an ERCP after that. So that's our that's management of biliary leak with and without peritonitis. Fenestrating cholecystectomy and closing the cystic duct orifice.
That's a difficult gallbladder, huh? Going back to difficult gallbladder.
Yeah, I think that's okay. When you say fenestrate, I suppose you mean opening the gallbladder. I think the important steps are to leave enough of the gallbladder behind to know that you're not. So this is, we met one of these recently, which was a type 2 Miritzi. So you could see when we removed the stone that there was a hole into what looked like the common bile duct. Not nice to see. So that we closed. We closed the cystic duct. And we actually closed the Hartmann's pouch and left a drain. It leaked, had an ERCP, got better. So I think fenestrating cholecystectomy, I do favor closing the cystic duct in general, because I think if there's a leak, then the size of the defect that it's leaking through is smaller. Therefore, a slightly better chance that it'll dry up. Good questions, though.
Very good questions. Can I continue to use
sure.
your expertise for us? So I think we still have time. It's just, what will be your advice, like in a practical now, for the surgeon that's in the middle of the night doing a cholecystectomy and realize that there was a bile duct injury? He or she doesn't feel comfortable to repair that. So what will be the practical step for the step? And if you contact any center, how to report the findings that the other colleague can give a support or an idea
really
for
good question.
Surgeon.
That's a really good question. Without being too gender biased, I think in my experience, we looked at that. I reported, we published my data about 10 years ago. We thought, should I publish my data of biliary injury repair now that it's a 20-year experience? I think there isn't anything interesting in it. It's the same as everybody else who does this. But I looked at the data on the Excel spreadsheet, and it's almost all male surgeons. I don't think I have any bile duct injuries caused by female surgeons. So I don't know if that means female surgeons are better. I think so. Does it mean female surgeons are more careful? I think almost certainly. I think there are different societal pressures as well, which obviously you will understand, Michelle. But let's not praise it, female surgeons any more than that in case I upset any men. But so we're in the middle of the night, bile duct injury. So that is a bad situation for everybody. I last met that a little while ago when there was an arterial injury and a bleed. It was 8 or 9 in the evening. I said, well, I can come there. And the problem was that they were saying, well, the anaesthetist wants you to stop because the operation has been going since 4 p.m. So I guess there's of responses. The one I don't like, but I guess we have to say because we live in the real world, is you can put a drain and refer it, and I'll take the patient after they wake up and they come. Much better, and my preference is to go there, and then I can assess the injury, see if there's a chance for primary repair. Even with a long tear, I met that on the day that me and my family were going to go on holiday, and I went to another hospital, repaired a long vertical tear. Almost all the bile duct had an anterior tear in it. That lady, it's about 2 years ago, her liver function tests are still normal. So I think it's worth, and what I did was I repaired it over an umbilical cannula to stop it narrowing down because you don't have access to an endoscopic stent. So options include drain and transfer, not so good. Surgeon visiting and doing a repair, better. And those are the two main things, I think. Or you could probably, I think globally, if you're in somewhere where it's not easy to get an HPB surgeon, which is most of the planet, it is also acceptable for the surgeon to say, I have to do the repair myself. But that's not so easy. I don't reckon in Europe, I don't think that's necessary. In Europe, you're sufficiently close enough to an HPB center of expertise that pretty much always you can get someone as an expert, at least have a discussion with them.
In case you go there to help do the repair and you find a concomitant vascular injury, you have a section of the right hepatic artery. Do you try to reconstruct it? Oh.
Yeah, so I wouldn't do a, thank you, that's now it's making even more difficult. Thank you, that's good. So I think I would accept, so with the right hepatic artery being cut, I know that people have reconstructed that, but it's very different to a planned right hepatic artery, actually a right hepatic artery reconstruction at any time is difficult, but a planned, say, common hepatic arterial reconstruction for cancer, that's a slightly different phenomenon because you will have proximal and distal mobilization, you'll have clamps, maybe you heparinize, you repair with a fine 5 or 6-0 suture. With this, it's been quite an irregular tear. So I'm going to accept that I have got proper control. So I'll find the hepatic artery stump, which will be there, and I'll close it formally. So I've accepted that the right hemiliver has lost its arterial inflow. Then find a roux loop, find the DJ flexure, divide the small bowel with a stapler, bring the distal end up, interrupted 4-0, I leave a right angle forceps in the bile duct. So it's very easy to close off inadvertently the tiny, because these ducts are usually not big, because if it's a primary injury, it won't usually be in a dilated ductal system. It'll be in a bile duct, which is less than 1 centimeter in diameter. So accept the right hepatic arterial ligation and a primary hepaticojejunostomy.
Thank you, very interesting. And my last question for you, if in your this 20 years experience of this topic and your team, if you had faced the case that once you get this very difficult, maybe get from another service to you with vascular injury, and also there's a complex that you have just to drain, and by time you try to repair, there is a total necrosis of the bile duct. You are unable to do a hepatic duodenostomy and you deal with these difficult steps. If you have any case that you had to indicate or consider a liver transplant for this case.
Yeah, that's a really good question. So I think in the UK, there are every year a small number of liver transplants done for patients who've had, but it's a small number, but it's not necessarily people who've had the injury now who have the transplant. Sometimes it's people who've had the injury before and they can't reconstruct. There's also a small number of patients who have liver resection for that. I have met that situation of that's really a heart worthwhile talking as the last thing. So no visible bile duct outside the liver. What do you do in that situation? And it's sufficiently traumatic that I can clearly remember it. So in that, if you meet it electively, what I do there actually, and I think I've learned what to do in that, which is you take out part of segment 4B. So 4B always has a exophytic curve. I call it the promontory of 4B. That it's so I'll have Pringle take out about 2 or 3 centimeters of segment 4 to find the left hepatic duct intrahepatically, and then you can get a rule loop onto that one. In that situation with that patient, I accepted that I probably could not find and reconstruct to the right hemiliver, and the right hemiliver, sure enough, became atrophic. And eventually that patient would have needed a reconstruction, but she died of another problem before that time. So that's probably the hardest situation. So I think it's rare that we'd hit a transplant straight away. Where transplantation as an immediate operation has had to happen in the UK is in the really bad situation where, and this has happened once in my part of the world in the last 10 years, where the surgeon has divided the hepatic duct, the hepatic artery, and the main portal vein.
Oh, thank you very much. I think that was brilliant. We have a brilliant presentation, discussion. I think it was very, very important. So thank you, Ajit, very much for being here with us and doing all this beautiful work. Thank you. And I'd like thank you, to tell the audience, the participants, about a couple things that the activities of the section, the UEMS section surgery. So the Surgical Thursday, this webinar will continue, and the next topic will be living kidney donation on June 8, 2023, by Frank Dorr, Imperial College from London. And on the September 14th, we have still a topic that will be defined, but will be run by the MJC Upper GI and the Emergency Surgery Division in cooperation of the UEMS Thoracic Surgery section. And other activities, what's next? Very important, the EBSQ exam in coloproctology, September 29 and the 30th, deadline to apply, 7 June, and the EBSQ exam in general surgery, deadline to apply, end of June, and the exam will be on the 13th and to the 15th of September. And we have from the EHPBA, the next exam will be on the 30th of September and Ghent, and deadline to apply will be July 10. Here you can find in this link all the information about those EBSQ examination. And please, the UEMS section of surgery is also in the social media. So we'll invite you to follow us. That's our address and how to learn more about the work we have been doing. So thank you all for your participation, for the registration. It was really a great evening with so much to learn. Thank you to all.